And so now it's my pleasure to turn it over to my colleague, Evan Merkhofer, who will introduce today's special guest.
Thanks, Barbara. So I'm very happy to introduce Marie Uebbing. She's a member of the graduate faculty here at the School of Nursing, and she specializes in preparing adult gerontology and family nurse practitioner students for their clinical practice. She has a BS degree in nursing from Columbia University, as well as a BA in medical anthropology from SUNY Purchase. She also has graduate degrees, including a Master of Science in Nursing and a Doctor of Nursing Practice from both of them from Pace University. And in addition to that, she's also a registered nurse. In addition to her teaching responsibilities here at the Mount, she is a practicing nurse, family nurse practitioner. And her areas of interest include wireless technology for patient-centered chronic disease management using avatar-based digital devices. And she's also a participating fellow at the Center on Aging at the New York Academy of Medicine, where she's working to develop innovative strategies for ensuring that elder persons have access to clinical care. So if everyone would join me in welcoming Anne-Marie for today's iROC presentation.
Thank you so much for attending. I really appreciate your presence, especially at the end of the day. We were just mentioning fatigue associated with long Zoom sessions. But moving ahead, I just want to first explain that this presentation really reflects my 2019 fall sabbatical. And I would like to present my merci and gratitude to the Mount St. Mary College Faculty Advancement and the Dean of Nursing, Susan LaRocco, as well as Denise Garofalo, Research Librarian, who are very instrumental in helping me, one, have the permission to abstain from teaching for 3 months and to really focus on research and travel to centers of excellence in patient simulation education. But 3 instrumental people that really helped me on the other end in the simulation labs were Philippe Legault, who's the Associate Director at the Steinberg Center for Simulation and Interactive Learning in Montreal, Canada, Quebec. Hugo Marchand, who's the Director of Simulation at the Ingram School of Nursing, University Montreal, of McGill University, and the Center for Medical Simulation, associated with Massachusetts General Hospital Institute of Health Professions, as well as the Nursing Department from Corey College, Boston, Mass. These are the people who are really instrumental in supporting me on my mission, which was the real purpose of the sabbatical, was to investigate a framework that would be sustainable at our school to extend the education of nurse practitioner students through using actual patients, which we'll discuss today. So I felt very strongly that we have both components in our education, which are formal didactic education in the classroom in a lecture format. I frequently did bring standardized patients into my classroom, varying from patients who have active Parkinson's disease to multiple sclerosis, COPD, chronic obstructive pulmonary disease, etc., and would use that to complement the didactic content. So I thought the next step would be to consider the relevance of having a dedicated lab for the purposes of simulating real clinical scenarios to best appraise the students' knowledge, potential use as a competency tool, and equally important, assessing their self-reflection, their personal experiences as patients themselves, if they've had them, and their personal biases and how they might interact with patients and how they may disengage or with patients as caregivers, which I think is a really important component in professional training. So the use of standardized patients, and they're known as, these are some terms to know, these are individual, they're SPs, that's the acronym that's universally used. And these are individuals, oftentimes they're paid actors, true actors, but many times they are trained individuals who can personify a patient. They are trained to study patient scenarios, review actual videos perhaps on patients with certain conditions, and simulate those signs and symptoms during a true encounter in a laboratory setting. They are also involved in the preparation of the student evaluation. So they are present in a classroom setting, perhaps to observe students, maybe distantly, just to see how they interact. And they modify and adapt their virtual patient role by making it more challenging, keeping it very real. And I'll talk about that in a moment. And this is really to enhance communication and interpersonal skills on the level of the clinician, so that the clinician can truly get accurate information from the patient, that the patient does not feel intimidated by the clinician, et cetera. It's been used since the 1960s, the concept of SP, standardized patients. Since the 1960s in medical education, it's pretty much a backbone in medical education. And it is a vetting process for physicians and physician assistants exclusively. It's required in their training. So it's been adapted for use in nurse practitioner programs, not unanimously, but that is the goal ultimately, because it is perceived as being a very high, what's perceived as high level fidelity training. So that is the term we're using, standardized patients. So again, just to reiterate, why are we using standardized human simulation in our training? Because the SPs can portray, this is a quote coming from Advances in Simulation, one of my sources in my research, systematic review of the literature to supplement my mission here, my query. They may portray an expanded role of or roles, clients, family members, healthcare professionals. There's an increasing recognition that SP methodology can be applied to the work of any individual portraying a human in any simulation modality. So just last night, I'm giving you an example. I had undergraduate students who portrayed a family, a husband and a wife who were arguing in an exam room over a patient's drinking, and that the contribution of heavy alcoholism and an acute gout presentation. So the student was challenged because they saw the patient and they saw the patient's significant other in the room quarreling, which is a real scenario in primary practice. So I wanted to bring that into the scenario. So just to reiterate, simulation has, as you're aware, has many different applications. Can be done virtually. We have done some, as you see in the center here, we have done virtual telehealth type sessions with our students where they have a scripted patient to evaluate, and they're observed by the clinical instructor, and they are given a debriefing, post-debriefing session. This is one modality that's used. The other is this type claymation presentation, which is used in some of our undergraduate education to simulate in a controlled way, but not a three-dimensional engaged in the laboratory type of experience. And then on the far right, your screen on the far right, there is an image of an actual simulation with a patient or individual who's scripted to be a real patient with a real complaint, with real lab reports, with real imaging, and as real as it can get out of virtually actually being in a clinical setting out extramurally outside of the campus. But by all, these are two other examples as well. This is a mannequin, very expensive mannequins. These cost in the millions, some. And here on the right, you have a hologram. This is a holographic representation, which is the artificial intelligent level of simulation that is being used in many campuses. So I interface with one, I just want to mention, the University of California, San Jose. So I worked with their department for a period of months to look at what they were doing, because they're one of the state of the art for simulation. Their budget is phenomenal. So I had I did not have that similarity, but it was useful, instrumental in my research. So here, right here on the right, you will see an actual simulation we did last night of patient drug seeking with a chronic orthopedic complaint. And one of our NP students here is doing the physical assessment and the intake of history. And the person on the left is the scribe who is actually documenting to provide continuity without disruption on a digital device. So this is actually one of our OSCE labs, which is a controlled laboratory in the basement of Aquinas, 100B, where there is a rear one-way mirror that can record students performing an assessment on an actual standardized patient. So just again, I reiterate that SPs are used for the preparation and training of nurse practitioners, physician assistants, medical students, engineers. In my experience in Montreal when I visited, were using this as well in robotics. It's a really beneficial controlled laboratory environment to simulate human conditions. Okay. So what's really nice about this concept is that the sessions are measurable and they're reproducible. So the student can be recorded. The recordings are archived. The student has permanent access to those recordings so they can observe themselves. This is very meaningful to the students because they can get firsthand knowledge of the word in French, comportement, how they engage, their rapport with the patient. This is something frequently that we dismiss in training. We focus heavily on the ability to get a detailed history of the patient and come up with a diagnosis, a differential diagnosis, potential other diagnoses for that condition, and then to very succinctly select the appropriate lab, the imaging, the additional consult to a specialist, et cetera. So we oftentimes lose sight of our presence in the room and the way we engage with the patient in terms of whether there are barriers, whether the patient has additional questions that are unanswered. So this gives the recording actually will be reviewed by the student, the patient, the virtual patient, or pardon me, the SP, as well as the clinical instructor. So it's an extremely valuable teaching resource. So my sabbatical focus, just to come back to that point, was initiated by a review of the literature to determine how SPs were being used in graduate nursing nurse practitioner programs, both in the United States, nationally and internationally. And what I did find was that in Finland, they have the greatest use, ironically, for simulation in their health sciences, specifically in the nurse practitioner and nursing programs. I did want to go to a conference there, but that was out of the question at that time. Then I observed some other clinical centers of expertise. These are centers that had been developed specifically by for instance, the Ministry of Education in Canada, which have provincial centers of excellence. So every province in Canada is required, they require their physicians, their medical students, their physical assistants, their nurses and their nurse practitioners to complete simulations. So both the Steinberg Center that I mentioned and the Ingram School of Nursing had parallel and intersecting simulation training. And I got to observe both, which was quite an eye-opening experience. Just to reiterate, the Steinberg Center is underneath the Montreal Metro. It is accessible to patients from the metro station. It's an urban designed center that is very strategic because it's not far from McGill, so the students can come over there, complete their testing, their competency testing, as well as practice. They can request, and the faculty can request simulation time, so the students segue from didactic learning right into simulation. and they are using standardized patients. They're using patients, individuals they've never seen before. So it's truly a very real scenario prior to going to their official clinical training sites. The opportunities on point number 3 here, the opportunities, as I mentioned earlier, in the simulation lab are really critical, not only for competency, for the ease of a safe environment for the students, so they're not feeling necessarily, if it's not a competency assessment, they're not feeling pressured. They have the opportunity to question, pause, rewind, review their recordings, is to explore the cognitive emotive skills that students need to know regarding poor prognoses, regarding disclosure of challenging diagnoses, for instance. So oftentimes, many nurse practitioners, medical students go through all of their training until they are now in the real situation where they've never learned how to give a terminal condition diagnosis to a patient. They've never learned how to bring bad news. This is a real area of neglect in a lot of education. So it is really important to have that opportunity to apply that in a simulation scenario. And again, the hallmark here is to explore, for me, ways in which my observations could be applied to the School of Nursing at Mount St. Mary College. How can I take this experience and materialize it in the way of a real simulation lab for our graduate students, which is desperately needed? So again, there was a systematic review of the literature. There was no strict evidence to show that definitively that simulation resulted in better patient outcomes, more greater competency of students per se. But and that is a very difficult assessment to make because we're seeing them in a controlled laboratory setting. We're not able to control those variables in a real clinical setting, but it can certainly suggest, and I believe it has very heavy potential to directly correlate with improved patient care, improved patient outcomes related to the way students were prepared in clinical simulation. So that's one point. And then I wanted to also, on a more minute scale, is to pool some of the data that some of the observations that I had at these centers of expertise for the purposes of our student. How could we modify our program both in a cost-effective way and the best way for our purposes to utilize the general concepts of simulation in our simulation labs? We have 2 brand new OSCE labs within a larger simulation lab in our school, which I invite you to come to see in the Lower Aquinas Building 100B. So that was challenging. We are starting new. We are just launching this program. And that was my next task, was to actually recruit students and recruit patients. I'll talk about that in a minute. So the clinical objectives of standardized patients in simulation, as again I mentioned, is extremely important. One, because of it allows us a way in a controlled lab to assess clinical competency, assess student safety. And that is taken from the point of view of the clinical instructor. It's also taken from the angle of the student, directly themselves as reported in a self-reflection. And it's also from the participating patient, the standardized patient's perspective. Did they feel that their questions were answered? Did they feel that they were likely to return to that practitioner? Did they feel respected? And were their questions answered, et cetera? So we're getting 3 different perspectives of assessment there. It also inspired students to have self-confidence, AKA a safety net, because the simulation lab was the center. If they were going to make a mistake, it was going to be in the simulation lab and get redirected on how to correct those mistakes. And again, of course, obviously the whole purpose is to enhance professionalism, to use that nest in the lab as a safety zone so that those students could perfect their skills. And lastly, but not least of importance, is the compassion, to really encourage students to think critically about the impact when they order a diagnostic test that could be potentially very painful. You know, you need to think twice about ordering tests. Are the diagnostic tests, do the ends justify the means? What does the literature say? Come prepared and understand the consequences of the test that you're ordering. And similarly, have the skills and have the wherewithal to reflect on your own personal experience or your familial experience with poor prognoses and discussing complex disease management in a way that's meaningful and how do I say, given in the best possible way that it could be given. Okay. All right, so it's pretty straightforward. I've already mentioned that standardized patients have many, many advantages. And clearly, I mentioned high fidelity. On the scale of being the closest semblance to a real patient experience, they cannot be intubated, that standardized patient. Many things can be, they can be used for other dynamics. I've watched standardized patients have a pregnant abdomen and have a midwife actually use the standardized patient to deliver a baby. So there was a woman speaking with the body of a mannequin, so that was modified. There are mannequins that are considered very high fidelity, which can be used for procedural interventions that train students, obviously. But standardized patients, for the purposes of our training as practitioners in family medicine, adult gerontology, are really just for the communication, the clinical assessment with no invasive procedures, obviously. So I mentioned that these three already, but what we really need to focus on as well is a standardized, validated instrument tool that can be used to assess students' competency, communication skills, and the accuracy of their performance with that standardized patient. And that is challenging because that is what makes it standardized, and that is something that is being worked on. So these are some other possible applications of adjunctive use of standardized patients, as I mentioned, using partial real individuals and using mannequins, which is for breast, pelvic, and genitourinary assessments. Okay, so in our population of the school, we have several pathways in the school of graduate nursing, nurse practitioner, and the pathways are adult gerontology, which runs the scope of age 13 years of age to end of life, family NPs, which are the scope of coverage is newborn to end of life, comparable to a general practitioner. And now we will soon be having psychiatric mental health nurse practitioners. So having a simulation lab that allows us to recruit and retain standardized patients for the purposes of educating and training as a resource to our graduate program is extremely, extremely important. And we are working, this is where we're heading right now. And next fall will be officially the first time that it will be incorporated into clinical practicum. Now, prior to doing this, I mentioned I did bring actual patients, my patients, into the classroom when I was lecturing on neurologic topics, for instance. But it made me think in terms of partnership in our community. We have a very vast range of individuals who would like to contribute to our School of Nursing, to the Mount. And similarly, we could contribute to those individuals as well. So I did actually interface with wounded warriors and the veterans about 4 years ago. And I was given a small stipend to invite veterans to participate in cardiac assessment as models, pulmonary assessment, advanced clinical assessment prior to students starting their very first clinical. They would have a random patient come in that they'd never seen before. And that was really what illuminated this idea that we really did need to have more volunteers and also reach out to our community. There are resources locally that we can use to build our pool of standardized patients. We also got a grant, fortunately, for a camera, which will be able to, what's the term? Retrieve, well, it will be associated with those two observation labs, OSCE labs, and we'll be collecting imaging and video recordings to a main control room where it will be converted to an MP4 and students will be able to archive those recordings on their phones, or ideally it will be in an e-class setting. So I talked a little bit about empathy, and this was quite startling actually to learn, maybe not surprising anymore, that I mentioned earlier that empathy is not something that is, it's not an allele. You're not born with empathy. It's something that is taught or osmotically, acquired, but reinforced in a culture. So what I did find in the literature was that it has to be integrated into education. It's not something that can be assumed, that it has been taught through individuals' parents or their family or the culture. So this is a quote coming from the psychology of resident behavior management. It's an Italian study, but that I found on very, very meaningful. The title is like Effective Expert Patient Teaching on Empathy in Nursing Students, a randomized controlled trial of about 144 students in 2019 in Italy. In the conclusion, the important takeaway from this controlled trial was that despite the fact that empathetic skills are essential for effective nursing care, studies have suggested that nurses have low or intermediate empathic skills, and patients suffer from this lack of empathic aptitude. So we need to bring it in. It has to be embedded in those SP scenarios to challenge students to actually test their empathic index. This really has to be explored. Now, in the Association of American Medical Colleges, there was also interesting, I'm trying to find where I got this one from, 2016, research looked at medical students' self-reported empathy and simulated patients' assessment of student empathy based on gender and ethnicity. And this also showed there were deficits, but in this particular study, what was meaningful was that the role of simulation did have a positive impact on enlightening students to what patients had to contribute to them at the end of those scenarios. These are simulated patients, that it did make a impressionable impact on those students and hopefully carried over into their professional careers. So I'm just looking at my time here. Okay. So the question is, when I'm thinking about developing these scenarios, how does one integrate empathy? How does it become a value in your measurement of the students' overall professionalism? So I'm trying to here explain that it should be considered an essential component in patient care, and it should be intentionally included in the scenario, and it should be a continuum throughout all of the training, from good news to bad news, so that the student learns to modify their own self-reflection throughout. Okay. These are just positives here. So I mentioned recruitment. I just wanted to say it has not been easy. I've gone to with some guidance from James Phillips in our theater department. I specifically had recruited theater students to see if they would find this to be a good opportunity for them to perform as actors. And then he had suggested, really insightfully, to recruit nursing students, because nursing students, after all, are going to be taking care of patients, and graduate nursing students who are established nurses can have a dyad relationship where they can each interprofessionally, because they are different elements of the same profession, they can reinforce teaching and through SPUs. So the goal here was to have undergraduate nursing students serve as patients and learn from the diagnoses, learn from the conditions, and learn also what it's like to be a patient. So this is an important element of training as well. So this is sort of a cross-pollination that I like to think of, that using undergraduate and graduate students can enhance and come a more holistic approach to cross-professional education within their own domain. It leads to dual learning opportunities, as I mentioned, and it reinforces that patient-centered care model that we are, that is our charge to maintain. They have real-time capture of student-patient encounters. There's that post-scenario discussion opportunity, the debriefing period with immediate feedback, both from the student, the patient, and the instructor. And each student gets a full debriefing. So it is a very meaningful experience to that student. It is cost effective if students are doing it. It's astronomically expensive if you have actual trained actors doing this. And hopefully, ultimately, this is something that is sustainable. As long as we have an undergraduate cohort and a graduate cohort, this can continue. That is what I'm looking at here. Okay. So in the future of standardized patient training, what needs to be the pillars of the training needs to be a formal training of standardized patients. So recruitment, retention of those nursing students, and either contractually or through their didactic teachers, and incorporating it in some manner into their curriculum, so they'll get credit for this as opposed to money. Learning how to adopt themselves to learn the script of the scenario, how to practice it and be proficient. Video recording the undergraduate students, the SPs, and showing them how they perform, and giving bridges, as I mentioned, course bridges, so that experience can count for something in their training as nurses in their undergraduate curriculum. So I mentioned already, we need to maintain a dedicated pool of standardized patients. We want to expand this to include pediatrics, women's health, and psychiatric. Right now, actually, we are focusing on family. Develop a student checklist so that both the undergrad and the graduate students have a map of where they are in terms of their aptitude and their assessment as far as benchmarks for progress. Then now we have bigger issue is maintaining a video recording archive in the lab, a quality recording that will be accessible at least during the 4 years the undergraduate student is there, as well as the 2 to 3 years that the graduate student is there. Let's see. And that's really it. So just the take home here is that we as a School of Nursing need to continue ongoing look at the literature, to look at innovative simulation technologies, what is best, what is most, what's the word, what can be materialized in our school, specifically regarding cost, and what are the best assessment tools that we can use that are show the best validity and you know, and have some dedicated review of the value of that so that it's meaningful in the preparation of not only our students, but our faculty. Our faculty need to be supported. This is a very big endeavor and it's very time consuming. So we're at the very incipient stages of this and it's very exciting. So thank you for listening. Do you have any questions?
That was so interesting, Anne-Marie. Thank you so much.
Thanks, Barbara.
Questions the folks have?
Can I recruit any of you as my I will be contacting you.
Elizabeth?
Sure. I thank you, Anne-Marie, and so good to see you. I haven't seen you in ages. And yes, you can recruit me. I was going to ask, could you? The only problem is if it's all nursing students, they may have had me in A&P and know that.
And their empathy towards you, Elizabeth, would you think that would increase their empathy towards you or not?
I don't know. I think that would be a really interesting question to find out, if I came in with some of my own issues.
Just so you know, I had a virtual patient last night who had a virtual baby and had bruises with highlighter on their arms. So, and was wearing a wig. So you can change your appearance. It's really interesting. I really encourage you as faculty and as anyone attending this talk to, experience what it's like to be ignored. I mean, we had a student debriefment where the virtual patient said, I felt that it was all about the baby and not about me. So I think this is a great opportunity. I'm really going to try to recruit faculty. Maybe we'll have some prizes, et cetera, for the best actor. But I just think as a humane experience, we've all been to physicians' offices. We've all been examined by an NP or a nurse. I think the proof is in the pudding. If you're now in giving your feedback directly to your future examiner, it's much more meaningful than neglect. I'm not sure that's an extreme word, but I think students need to know, not be so cocky as new clinicians, young clinicians, that people do suffer and people do have life-changing events and need that experience.
I had one comment and then one question. One comment was that I really think it's a brilliant idea to match the nursing with the undergraduate with the graduate. And then I was wondering if perhaps through psychology, you could also bring in observers, perhaps from maybe some of the seniors would be wanting to look at that kind of dynamic, and also maybe the health advocacy program when it matures, to get their input and maybe again expand the network, so to speak, on supporting this project. So you sort of answered my other question because I wasn't really clear. You are already doing some of these simulations now. You said last night you just did something.
Last night we had 10 orthopedic complaints, and with everything ranging from ganglion cyst to a complicated sciatica neuropathy in a truck driver who was drug addicted. These are real scenarios for my patients. So I had a patient who was drug seeking in extreme pain, who didn't have health insurance. These are real scenarios. So then I had another where a young woman had a rotator cuff injury and she had a broken shoulder from a domestic violence issue. So, these were not by any means straightforward clinical presentations, but it really begged to question, why don't we have social services in healthcare? Why don't we have better, real patient-centered care models in our clinical practices?
And then, do you debrief the student right away, or do they just
because
we would think that might be emotional for them too, in the sense of, oh my goodness, that was much harder than I ever thought it would be?
Yes. Now you have to understand, the graduate nurse practitioners, the average student has between 6 and 20 years experience as a nurse. So they have most likely seen a lot. Most have pretty much pronounced death and that kind of thing. But The problem was we had such a big group. I had 20 students broken into pairs of 2s, 10. So there were nine students in one section broke into further groups, and we had separate clinical instructors. So they would debrief separately. So the patients would come out of the exam rooms and go into the lecture and stand in front of the students and literally tell them, 70% of you were accurate. They knew the diagnoses and they knew the differentials. These are nursing students. Several of you never introduced yourself to me. That's pretty profound. You never told me who you were. So that was very meaningful. So, you know, regarding your question, Elizabeth, yes, it would be wonderful to have interprofessional presence. It's still a relatively small space. If you know the lab, we'd have to fix it in a way that it was manageable. You know, this is a very intimate experience. You can't really have large groups. Ideally, you shouldn't have more than 4 students and an instructor total behind that rear view mirror. It's a very, it's like a theater production. You know, you have a spotlight, you have a director, that kind of thing. So
yeah, and so interesting. I wonder also though, perhaps you could just, you know, if you're recording, you could have that recording go to other, you know, the other undergraduates if they're
yeah, that's the hope, that it will be a learning tool that we can, you know, because of COVID, we weren't able to teach on ground. So a lot of us resorted to virtual experiences, and this, you're right, this is a potential, you know, supplemental resource for teachers, for faculty. Yeah. So I hope that it maybe contributed to anyone's teaching that, you know, anyway, there are many applications to simulation. I think, but we definitely need to integrate it into our health professions. That's for sure. You know, in nursing, nurse practitioner program.
Until COVID struck, I was providing this type of use for Touro College students in Middletown, the medical students out there. I didn't realize the Mount has something like this going, so I'd be more than happy to work with the Mount on doing some of this.
Well, thank you, Vincent. We'll definitely be in touch. Yes, medical schools are obligated by mandates to have simulation. It's mandatory. They are vetted. Physician assistants have to pass with a grade of 70 on a competency assessment. They get 2 options and they're out of the program. So standardized simulation as a vetting process is the norm in medicine and in physical assessment training. It can be very, very stressful. It is essentially like a board exam. It's probably more intense than a board exam because the student is being observed by no less than 3 faculty usually. So
interestingly, in pre-licensure nursing, though, the state does not acknowledge simulation at all. If you cannot use it as a substitute for clinical hours. Most of the schools do, but the state still does not acknowledge it. We're one of the few states, I think, that just totally act like simulation doesn't really exist for pre-licensure.
Yeah, well, that's a very important topic. One, it is meant to be a segue, a platform on which to kind of evaluate prior to actual patient direct clinical, you know, rotations. And it's also used as an intermediary tool to assess at specific milestones if you are meeting certain standard requirements. I think it's not to be used exclusively as a substitute by any means. It's really more of a, how do I say? It's a culturalization. It's an opportunity to simulate and to give students the opportunity to possibly make their errors now, or to be challenged with complex, you know, patient experiences and learn strategies in a safe environment so that they can feel more confident when they're on those rotations. I don't think it's necessarily a substitute, but during COVID, this has been a question.
But Anne-Marie, the study that was done by the National Council said that you could use up to 50% of your clinical hours as simulation, and it didn't impact their NCLEX scores, nor did it impact employer satisfaction with readiness to practice. And New York just totally ignores that study that was done about 6-7 years ago. I mean, they act like it doesn't even exist. It's
This is
unbelievably backward
okay. So you're referring specifically to RN,
to
undergrad
pre-licensure.
pre-licensure, right? Okay.
Yeah, I don't think they have any stipulation for NP programs that I'm aware of, but they're very clear. And the Dean's Council has been fighting with them for a long time because it's just, it's not appropriate to say it doesn't count.
Susan, I have to ask you, in Massachusetts, is this the case?
I don't think so. We have never heard anybody say you couldn't use it as a substitute there.
Okay. Yeah. So I'm not sure if you're all aware, I mean, Susan is clearly, but so many of these regulations vary so much state to state, and it's very confusing. I'm just coming from a national organization of NP faculty conference today, and no one can even, we won't talk about it, but there's so much interstate variability that it's very frustrating. I can't imagine what a dean has to encounter. But yeah, that's a very good point, Susan. Thank you for raising that. That's disturbing. I don't know. I'd like to know what the rationale is. I'd like to know why that was not, like you said, it's been a covert kind of research. So I'm going to look at that.
There's a question from Colleen in the chat. Colleen, did you want to ask it or?
Yeah, sure. The question is, do you create scripts that you hand the undergraduate students, or do you just give a few details about who they are and what they are experiencing in terms of diagnosis, symptoms, presenting complaints, or do you give them like detailed scripts? Scripts
Okay.
or just an outline or a framework?
Right, good question. So for the virtual patients that we had online, they were given actual scripts. For the simulations we did last night, because they were focused simulations, the undergraduate students received x-rays, MRIs, images to best simulate. I had photographs of a gouty foot. I had photographs of a Boxer's or Cole's fracture from imaging. I had a pre-septal bursitis, so they had a knee that was clearly cellulitic, you know. So the image would be shown, the lab information would be given to the student, and the student would interrogate the NP student would interrogate the standardized, the SP, you know, the undergrad. What brings you here, how long you know, a chief complaint and history of the chief complaint, a focused review of the system. So they'd focus on the knee, it's prepatellar bursitis. And then they would be giving between 10 and 15 minutes, that's what an NP gets, to give a diagnosis, differential, and a plan. So they had literally 10 to 15 minutes per session, and they were timed to move through each exam room. And that's virtually what you do in a clinical setting. They were given the caveat, you were mentioning the script. Some of them were given the caveat of drug-seeking behavior, which is going to add another 10 minutes to that visit. Or potential for domestic violence, that's going to expand that visit. So that's the reality, every day-to-day practice for an NP. So that's what we did. We have user scripts ideally, but the undergrad students were given the opportunity to study their condition. They had to know the differential diagnosis. They had to know the tests that were going to be indicated. They had a herniated disc. They would have to know a straight leg raise. They'd have to know for epicondyle, tennis elbow, epicondylitis, lateral epicondylitis. They'd have to know some of the tests that were done and some of the imaging. So the undergrad had to do their research. They could embellish their symptoms based on that content. So it was a little bit of a creative process.
It's great. Thank you.
You're welcome.
Any other questions? Anne-Marie, how much training do you have to give the standardized patients?
In an ideal setting, Susan can share this because she was one. The standardized patient has to be, because they're standardized, they have to actually be observed, participate in a in a meeting, what is the standardized patient? What are your roles? What are the expectations? What are the parameters? The time you have to arrive on time, you have to be prepared, you have to be available. You know, this is unlike some students who might cancel on the day before. That kind of scenario does arise. But there are formal standardized patient programs that are usually sponsored by schools and centers of simulation expertise. That's not to say that a student cannot be taught these skills. To use a script verbatim is a different story, and that does take practice. And maybe Susan, you want to share your experience as an
I think it varies a lot on what you're going to expect that standardized patient to do. For example, I was a standardized patient for physical therapy students who were going to observe my gait and make a determination. I mean, basically, they were very early in their career students. It was an exam, and they were being observed for, did they put a gait belt on me? Did they introduce themselves? I didn't have to do much practicing for that one. Another night, though, at Mass General, I was part of, there were two of us together as standardized patients. I was the older one, and then my caregiver was with me, and we were being interviewed by several people on a rehab team. And we were supposed to be arguing, you know, they'd ask how much I smoked, and I would say 2 cigarettes, and she would say, no, she doesn't. I go out and buy her 2 packs every day. And, you know, so they had to learn how to control us. So they put a little more time into preparing us for that one. But Mass General has a huge program on this at the Institute, and very well funded. It was easy to be a standardized patient there because they were paying me as much as they were paying nurses, you know, in the nursing home. So, but I think Anne Marie is so on target with this. I can't tell you how important what she's doing is. And the grant that we got, the internal grant that is providing some videoing and stuff, it is absolutely, and we do need to have a little more dedicated resources for it to do the standardized patient. I mean, we have Stacia's our sim director, but between graduate and undergraduate, we really need more. And I certainly, before I'm gone, will be advocating for more, either just release time or another part-time person or something, because Anne Marie has completely nailed what we need to do. And yet without the resources, we can't just keep asking faculty to do more. So that's my story. Thank you.
So we're just about at 5 o'clock, and I know a number of people will have to leave, but I don't want to cut anybody off in case there might be another question. I did put that link to the MSMC YouTube channel in the chat if you want to grab that there. Anne Marie's talk will be up, you know, in the next day or two, but you could take a look at previous iROC presentations, including Dean LaRocco's presentation from a few weeks ago. So I encourage you to do that. I think most students who are here have given us their information about FYE or credits or courses that they're looking for extra credit on. Just wanted to remind you of the Student Poster Symposium on May 6th at 4 p.m. And I want to thank Anne Marie for, you know, taking the time to talk with us about what she accomplished in her sabbatical and the implications for us here at the college. And I'd like to thank all of you, of course, again, for spending a little bit of time with us this afternoon.